So first of all, thanks all, give me this tremendous opportunity to talk about FIPES at this prestigious conference. But why we need to talk about FIPES? FIPES is an acronym meaning food protein induced enterocolitis syndrome that is gaining recognition. However, there continues to be delay in diagnosis and misdiagnosis due to the overlap of symptoms with other conditions and lack of diagnostic tests. Generally, gastrointestinal food allergy are classified according to their underlying pathogenesis, and adverse food reactions are divided into immune-mediated reaction, for example, food allergy, and non-immune-mediated reaction, for example, food intolerance. The term food allergy is used to designate an immune-mediated adverse reaction to food protein. These include IgE-mediated food allergy, mixed IgE and non-IgE mediated food allergy, and non-IgE gastrointestinal food allergy. In IgE food allergy, reactions generally occur rapidly after the ingestion of the food. Although isolated gastrointestinal symptoms can occur, this clinical picture can be also accompanied by other features affecting the skin, for example, endomucosa, but also respiratory tract or cardiovascular system, and can present as a life-threatening anaphylaxis. Reaction in mixed IgE and non-IgE mediated disease, such as eosinophilic gastrointestinal disease, are triggered by complex immunological mechanisms. While on the other end of the line, non-IgE gastrointestinal food allergy, in which circulating food-specific IgE are typically absent, and disease include FIPES. Although the underlying pathomechanism is still poorly elucidated, this entity may represent a continuum of disease where the expression of symptoms and severity is dependent upon the affected segment of gastrointestinal tract. And specifically, a heterogeneous disorder associated with a number of geographic variations in the feature of disease, representing a spectrum of syndrome as opposed to uniform syndromes. Specifically, FIPES is a non-IgE mediated food allergy that typically presents in infancy, with repetitive protracted vomiting that begins approximately 1 to 4 hours after food ingestion. Vomiting is often accompanied by lethargy and pallor and can be followed by diarrhea and culminating in hemodynamic instability and hypotension in at least 15% of reaction. Also, delayed onset and absence of cutaneous and respiratory symptoms suggest a systemic reaction completely different from anaphylaxis. FIPES can affect the entire gastrointestinal tract, causing symptoms of emesis, which can be severe enough to cause metabolic disturbance. What about the FIPES prevalence? FIPES incidence vary greatly, and just in only one single published work, Prospective birth cohort study, authors report a cumulative incidence of infant with cow milk-induced FIPES of 3 per 1,000 newborn. The pathogenesis of FIPES is poorly understood. Many groups have shown the presence of specific T-cell response to causative antigens, with an imbalance between the synthesis of TNF-alpha and TGF-beta. This led an initial understanding of disease as being the result of local T-cell infiltration and inflammation, causing an increase in intestinal permeability, with a subsequent fluid shift and increase in antigen influx. Recently, serotonin has been clearly implicated in a symptom of FIPS, although it is not clear if serotonin is involved as a peripheral trigger of reaction or is restricted to central control of the vomiting reflex. Immune characteristics of FIPS patients also include broad systemic innate immune activation of monocyte, neutrophil, eosinophil, and release of cytokine into the systemic circulation. Moreover, Th2 response, which are typical of IgE food allergy, have been also described in FIPS patients with increased production of interleukin 4, 5, 9, 13. And probably this phenomenon, which may be explained by the fact that there is also an high risk of co-atopy seen in these patients. The most commonly reported FIPS triggers are cow milk, soy and grain, soy-induced FIPS and combined soy, cow milk induced FIPS are common in USA, but uncommon in Australia, Italy, and Israel. Most reported solid food-induced FIPS is attributable to rice and oat. FIPS also occur once with solid food, but also with cow milk and soy-based formula or both, and generally introduced into the infant diet, usually between 2 and 7 months of age. Infants with cow milk and soy-induced FIPS typically present at younger age, usually less than 6 months of life, compared with those with solid food-induced FIPS, in which the clinical presentation range from 6 to 12 months, reflecting early introduction of cow milk and soy. The median age of solid food-induced FIPS onset is similar between most series, with grain-induced FIPS presenting before FIPS to fish, eggs, and poultry. So multiple factors can be also involved to explain this geographic variation, including difference in the population, but also presence of atopic disease, breastfeeding, and dietary practice. Usually, symptoms break out when formula milk or solid food are introduced for the first time, but they may be also appear in exclusive breastfed infants, since the trigger elements, especially cow milk protein, can be conveyed by maternal milk as well. FIPS is exclusively breastfed baby is a very rare clinical condition, and only a few cases have been reported in the medical literature. FIPS clinical phenotypes is influenced by the age of onset, nationality, timing, duration of symptoms, and the association with the IgE phenotype. Also, FIPS can be further classified according to the timing of symptoms in acute versus chronic, also in accordance to the age of onset, in early onset, late onset, or adult FIPS, the type of the triggering food, cow milk, soy versus solid food, and the presence of food-specific IgE. So in this case, we talk about atypical FIPS. But this cartoon is illustrating also the possibility of a fluidity of FIPS phenotype in an individual. This case scenarios is in fact based on our clinical experience, in which chronic FIPS, for example, manifest in a young infant who subsequently, after food avoidance in his diet, reacts with acute FIPS. FIPS can also be classified according to the severity of a clinical manifestation in mild, moderate, and severe. The manifestation and severity of FIPS depend also on the frequency and dose of the triggers food, as well as the phenotype and the age of individual patients. The distinctive pattern of emesis starting within 1 1 to 4 hours after food ingestion, acute FIBS, occur when the food is ingested intermittently or after periods of avoidance. Watery diarrhea develops in some cases within 5 to 10 hours of ingestion and can be present for up to 24 hours. Symptoms of acute FIBS usually resolve within 24 hours after food ingestion. And in most children with acute FIBS, they are well between episodes with normal growth. Chronic FIBS is less well characterized compared with acute FIBS and only reported in infants younger than 4 months of age fed with cow milk or soy formula milk. Chronic FIBS develop on regular or repeated ingestion of a triggered food, presenting as a chronic emesis, watery diarrhea, and failure to thrive. Severe chronic FIBS can lead to dehydration and shock. Hypoalbuminia and poor weight gain can predict chronic cow milk-induced FIBS in young infants with chronic gastrointestinal symptoms. So this is the major criteria and minor criteria that we need to make a diagnosis of acute and chronic FIBS, respectively. The diagnosis of FIBS is primarily based on clinical history of typical characteristic signs and symptoms, with improvement after withdrawal of the suspected triggered food. So, accordingly, do not routinely perform testing for food-specific IgE to identify food trigger of FIBS, because FIBS is not an IgE-mediated process. However, because some patients with FIBS can exhibit coexisting IgE-mediated allergy, testing can be considered in these patients. Assessment of blood counts can help rule out other causes of symptoms if obtained in acute setting. But remember that the majority of patients with FIBS have a negative skin prick test response. So what about the role of the patch test? Usually the patch test seems to be a promising diagnostic tool for the diagnosis for FIBS, but other studies reported that they have poor utility in the follow-up prediction of outgrowing FIBS in children. Unfortunately, but it is also important to exclude other potential causes of gastrointestinal symptoms and use oral food challenge to help confirm the diagnosis if the history is unclear and there is also a favorable risk-benefit ratio. For example, metabolic syndrome, multiple food protein intolerance, but also immunodeficiency and dysregulation syndrome, and also early onset inflammatory bowel disease must be considered in those presenting with suspected FIBS. This is especially the case if the child has a co-associated failure to thrive, hepatosplenomegaly, persistent diarrhea despite appropriate food elimination, persistent elevated inflammatory markers and reaction to multiple different food protein. Thus, if the diagnosis is unclear after taking a careful history, the oral food challenge should be used as the gold standard to confirm the diagnosis. But it's also important to know the diagnostic criteria for the right interpretation of oral food challenge in patients with a history of possible confirmed FIBS. The OFC, the oral food challenge, will be considered diagnostic if the major criterion is met with at least 2 minor criteria. However, authors suggested 2 important caveats to this criteria. The first one is the rapid use of ondansetron. Thus, in this case, many of the minor criteria, such as vomiting, pallor, and lethargy, can be averted. And the second point is that not all facility performing challenge have the ability to perform nutriphilic count in a timely manner. Also, after that, so now go through the management of this condition. It is important to manage acute fibs individually according to the severity and review the treatment strategy with the caregiver of each patient, specifically treat acute fibe as a medical emergency and be prepared to provide aggressive fluid resuscitation because approximately 15% of patients can have hypovolemic shock. Consider also ondansetron as adjunctive management of emesis in patients with acute fibes, and at least use dietary elimination of the trigger food or food for the primary management of pies, and educate caregiver and other caregiver provider regarding avoidance strategies. Children with food allergy, unfortunately, have been noted to have deficiencies in energy, protein, vitamin A, G, and calcium, iron, and zinc. Infantile fibes is a risk for deficiency caused by dietary restriction and delayed introduction of new food. Limited food experience can adversely affect food intake for many years to come. And it is also, and these patients unfortunately can also show a high risk of cross-reactivity and or co-allergy. So it is commonly recommended that the caregiver introduce a new food as a single ingredient, and in the case of high-risk food, to wait at least 4 days before introducing another food to observe for development of a reaction. Also, providers should recognize that even single food elimination can be associated with a significant nutrition deficit. Thus, consultation with a dietitian is highly recommended to facilitate the weaning. The cornerstone of the management of non-Ige gastrointestinal food allergy is the removal of offending food from the diet. Depending on the severity of the symptom and on the quantity of triggery food, two different strategies can be adopted. The first one is a bottom-up approach, in which causal food are successively eliminated without broad restriction of unsuspected triggers. Usually it is used in most cases. Another approach is the top-down approach that may be warranted in most severe cases where failure to trial and the rotation appointment. This approach consists of initial avoidance of a wide variety of food, sometimes starting with an elemental diet with a sequential reintroduction of the individual food, while carefully monitoring for recurrence of symptoms. But what is the natural history of non-Ige gastrointestinal food allergy? But usually is most favorable, with the vast majority being outgrown by school age. Fibes generally resolve before 3 to 5 years of age, but this may vary by type of food. Usually, an older age at diagnosis and atypical fibes are associated with prolonged symptoms. But complexively, all patients had fibes within the first 6 months, and by the age of 3 years, 90% of patients had recovery. Older proportion may convert to Ige gastrointestinal food allergy. In conclusion, fibes is emerging condition and no absolute criteria and laboratory investigation are available. Confirmed diagnosis of fibes is clinical and is consists in elimination and oral food challenge. Emergency management are fluid resuscitation and supportive medication. The prognosis is good, but unfortunately we need, there are so many unmet needs. So we need to validate the proposed diagnostic criteria. We need to standardize the oral food challenge. We need to determine the pathophysiology of the acute chronic phase and also to detect a non-invasive biomarker for diagnosis and for monitoring for resolution. Lastly, we need to develop a new therapeutic approach to accelerate FIPE resolution, and further longitudinal core study are awaited. Thank you so much for your attention.